Good evening, good afternoon, or good morning to everyone, depending on which part of the world you're joining in from. And a warm welcome to today's GHQA Wednesday webinar. Thank you all for joining for this important session titled HIV Global Updates, reviewing the World AIDS Day 2025 US AIDS Report, Overcoming Disruption, Transforming the AIDS Response. We are delighted to have participants joining us from different parts of the world. GHQA is a global platform committed to advancing healthcare quality, patient safety, public health awareness, and leadership development. Our mission is to empower professionals and students to contribute meaningfully to healthcare systems through volunteering, research, projects, and capability building initiatives. Today, we are truly honored to host Dr. Joan Duggan, a distinguished leader in infectious diseases and a highly respected clinician, educator, and researcher. Dr. Joan is a professor of medicine at the University of Toledo College of Medicine and Life Sciences, and for the past 25 years, she has served as the principal investigator and medical director of the Ryan White HIV program, ensuring comprehensive HIV care across Northern Ohio. Dr. Joanne completed her bachelor's in biology from University of Michigan, followed by her MD degree and a residency in internal medicine from Medical College of Ohio, followed by fellowship in infectious diseases from University of Michigan and a master's in public health from Yale University. Her academic contributions are remarkable. She has authored 78 peer-reviewed publications, 85 abstracts, and 7 book chapters. She has received numerous honors, including Leonard Tao Humanism in Medical Award, several Leans Award for Teaching Excellence, and being recognized as one of the best doctors in America. Beyond her academics and clinical achievements, Dr. Joanne is deeply committed to improving patient outcomes in HIV, pre and post exposure prophylaxis, congenital syphilis, STDs, and broader public health challenges. It is truly a privilege to have with us today to share key insights from the World AIDS 2025 UNAIDS report and to help us understand where the global AIDS response stands today and where it needs to go. With that, I am honored to invite Dr. Joanne to begin today's session. Ma'am, the floor is all yours.
Thank you so much for that wonderful introduction. Can you hear me okay?
Yes, ma'am.
Perfect. So I'm going to share the slide set, and when I do that, I'm going to take over the screen. And when I do that, I can't see the chats or hands up. So please feel free to interrupt if you have any questions, or else put them in the chat and we'll go over them at the very, very end. So with that in mind, let me share this, and I need y'all to tell me if this is looking okay.
You can just make it a little bit bigger.
Okay, yeah, let me hang on a minute. Let me stop the screen. Let me go back. I want to try something else here. Hang on 1 second for share. Let me just try this. Share. Let me try that. Can you guys see it now?
Yes, ma'am.
Is it still small?
It's still small. Yeah.
Is it bigger now?
Better now,
This is
yeah.
much, yeah.
How about now?
Much
Much
better.
better.
Much better? Okay, great. All right.
And we can
So
try the full screen. It's at the end on the lower end. Yeah, this one. So there's a sign just next to the mouse cursor. That's for the full screen. It's just a little left. Yeah, this one.
it's not letting me do that. Unfortunately, I'm so sorry about that.
Let's continue this way.
If you wanted to, I can start the screen sharing and you can put it up and I can just say next slide. No, okay, great. All right. So just to set the stage for the World AIDS Day update for this year, for 2025, as a reminder of where we were, where we are now, and where we're going, on February 5th, 2019, during his State of the Union address, United States President Donald Trump actually announced the U.S. Public Health Department's and CDC's initiative to end the HIV epidemic in the United States within 10 years. So the 2030 goal that the World Health Organization had set. And in order to end the HIV epidemic, EHE, in America, the goal was to decrease new infections by 75% and within 5 years, and by 90% within 10 years. And fast forward just 6 years, and all funding for HIV programs has been paused, and the United States is pulled out of the World Health Organization. So the World AIDS Day report for 2025 is about overcoming disruption and transforming the AIDS response. And there's really truly been a global sea change in the world of HIV care just in the last 5 years. And I want to just read from the few words from the director. This report shows at the end of 2024, just before the sudden collapse in funding triggered by the U.S. withdrawal of efforts in the global HIV response, new HIV infections were down by 40%, and AIDS-related deaths were down by 56%. But what does the future hold? We don't know. And this is capped with a literally transformative opportunity in HIV prevention due to the initiation of and approval of lenacapivir, an every 6-month capsid inhibitor that is a game changer for HIV prevention. So with that in mind, let's take a look at what the actual report says. Let's take a look at lenacapivir as the just really a brand new intervention that's going to be a game changer for HIV prevention, and then some of the issues in potential funding going forward. So remember that the World AIDS Day report, December 1st, 2025, or December 1st of the year, always reports all the data up to December 31st of the calendar year before. So this is the data as of the end of 2024. And currently, we think there's about 41 million people living with HIV, giving a global prevalence for adults of HIV of about 0.7%, so less than 1%, 0.7%. We're still looking at about 1.3 million HIV infections per year, and still over 500,000 deaths each year due to HIV. We think a little bit less than 100 million people, 91 million people, have been infected with HIV since the start of the epidemic in 1981. And about 44 million people have died from AIDS-related illnesses since the start of the epidemic. So this is a picture of adults and children estimated to be living with HIV in 2024. And as you can see, the large area where the main problems exist are West Central Africa and Eastern Southern Africa, with growing numbers in Asia and the Pacific region, and really some stabilization of numbers in Western and Central Europe and North America. This is the global data, and I hope you can see my mouse as it's running across the top. Okay, good. So this starts with 2020 and goes to 2024, and people living with HIV has increased because we're not losing people to HIV like we used to. The death rate is down significantly, and in fact, with an undetectable viral load and immune reconstitution, we expect people to have a normal life expectancy. New infections are also down significantly from 2020 because of U equals U. If you have an undetectable viral load, you cannot transmit HIV sexually. That's defined as a viral load less than 200 copies per cc, okay? But the big issue is here, people accessing antiretroviral therapy. We've got about 31 1.6 million people now accessing effective antiretroviral therapy. But the goal in 2025, and unfortunately, I wish you could see the slide set all the way down. The number was supposed to be 34 million people on with HIV on prophylaxis by 2025. That was the target goal in order to hit our reductions. And when we don't have enough people on antiretroviral therapy, we have people with detectable viral loads, we have not broken the chains of transmission, and so we're still getting new infections every single day. So this slide is going to have infections on a day-by-day basis. The next one will have it on a year basis. Still, every day, about 50% of the new infections that we're seeing are occurring in sub-Saharan Africa. Less amongst children, those less than age 15 years old, so before, generally considered before sexual debut for most children. And about 3,300 of these new infections, a significant majority are occurring amongst women and younger people. These are women also of childbearing potential. Now, the peak is down significantly since the 1990s, but in 2019, 2020, right before COVID hit, our target for new infections was 370,000 new infections per year. We are still at 1.3 million. So we're still almost 5 times higher than we want to be. And again, since a large number of these infections are happening in women and girls, these are also going to be happening in women of childbearing potential. So these are the numbers when looked at across an entire year. The first were day by day. And so we're still seeing large numbers of new infections, again, in Eastern and Southern Africa, but catching up is Asia and the Pacific, which is this area here in green. For children, there are 1.4 million children living with HIV, and we have children infected perinatally from the 1980s who are still alive, still doing well, now having children of their own. And we're looking at this group at new infections still over 100,000 per year, with death rates still about 75,000 per year. While the numbers of new infections in children, perinatal transmission, have largely declined, they are not yet eliminated. And when you look at this map, this really reemphasizes that it is possible to almost essentially eliminate perinatal transmission, which is generally where children less than age 15 years are estimated to be living with HIV. That's where that group comes from. It is possible to, or really minimalize it if we have women of childbearing potential tested for HIV, and before pregnancy or early on in pregnancy, achieving an undetectable viral load and then maintaining that through breastfeeding. But without that, it's impossible to obtain those numbers. And due to the very intense effort in Western and Central Europe and North America to decrease perinatal transmission, we basically have negligible numbers of children estimated to be living with HIV in these regions. That is compared to other areas where numbers are in some cases growing. And this will give you an example. Estimated number of children newly infected. Areas where we're still seeing growth include Western and Central Africa, Eastern and Central Africa, Latin America, and again, Asia, the Pacific. And this just reemphasizes some of those numbers. So in some ways, with the introduction of protease inhibitors in 1996, and then their widespread institution within the next 10 years, we have seen decreases in the number of AIDS-related deaths. So we are still making significant progress. But in 2015, we had set goals for 2025 and 2030 to have significant decreases in new infections and AIDS deaths and we are nowhere near now to meeting those goals. So shifting a moment to AIDS-related deaths, again, since the introduction, the decade after the introduction of effective antiretroviral therapy, we've had reductions by 70%. So we have made progress in that area. But every minute, somebody is dying of an HIV-related and AIDS-related illness every minute in 2024. And that is largely due to the lack of access to antiretroviral therapy, to sustained antiretroviral therapy. So estimated child and adult deaths from AIDS, again, less in areas where access to antiretroviral therapy is readily available, plus testing and monitoring. And so the areas of greatest concern are Western and Central Africa, Eastern and Southern Africa, and then again, Asia and the Pacific. And in children, the picture again is in resource countries like Western Europe and North America, a much, much different picture than in Africa and Asia. So shifting to some of the regional profiles that were rolled out by the World Health Organization and UN AIDS for World AIDS Day. One of the most important things that comes out for the regional profiles for Asia and the Pacific is the treatment cascade, which we're going to show us the next slide. The testing and treatment cascade. Ideally, again, our target is 95% of people living with HIV know their status, and 95% of those people living with HIV are on treatment, and 95% of those people have a viral load that's undetectable, meaning less than 200 cells, copies of the virus per cc, because they won't transmit HIV. And that's how we break the chains of transmission. And Asia and the Pacific is still not where we need to be for people knowing their HIV status, so that's testing, having access to antiretroviral therapy, and being able to take them in a sustained manner to decrease their viral load. The resources available right now in US dollars to meet these goals are $3.2 billion, but that's about 50% of what is thought to be needed to hit the 2030 targets to try to eradicate HIV. So when we take a look at the HIV testing and treatment cascade by age and sex, if you just take a look at the total population, these are the numbers here. And ideally, we want them at 90, 95, 95, 95 all across the board in order to really start to move the needle. We're not near where we need to be. And again, the group that is having the worst outcomes are young children living with HIV, in terms of knowing their status on antiretroviral therapy and having an undetectable viral load, because that will also give them immune reconstitution and improve their health. When we turn to West Central Africa, again, the treatment cascade is actually looking a little bit better. It's pretty similar here. But resource availability for HIV, again, is decreasing. And it's thought to be $2.2 billion, which may fall short of the goals needed to hit 2030 testing and treatment cascade goals. So in Western and Central Africa, women aged 15 years and up, so 15 to 49 and women of childbearing potential, we're actually doing relatively well in having women know their HIV status, getting prescribed antiretroviral therapy, and having the end result of an undetectable viral load. This will decrease transmission as well. When we take a look in Eastern and Southern Africa, again, we're doing better, but we're not near where we need to be to hit our 2030 goals to end the HIV epidemic. But when we take a look at women living with HIV who know their status, in Eastern and Southern Africa, we're at 95%, 93% overall of the population with excellent excellent viral load suppression, which are key to ending the epidemic. Unfortunately, though, when we look at children, we are still not making the mark. Everybody who knows their HIV status should be on treatment, and we should be monitoring and adjusting it to make sure it's effective. But in this group, not coming near where we need to be. When we shift over to Western Europe and North America, we actually aren't doing as well in terms of the treatment cascade as we are in Eastern and Southern Africa. And generally, the data is not out yet for 2024, and I don't know when it will be released, but in the 2022, 2023 data, we only had about 55 to 60% of adults with HIV in the US, for instance, actually having an undetectable viral load. We were not anywhere near where we needed to be to hit goals to end the HIV epidemic. When you look at the regional profiles that were put out by UNAIDS, these are really the pictures down here that show the story in just a nutshell. There are numbers of new infections in the blue, and then the orange are deaths, HIV-related deaths. And areas like Eastern and Southern Africa are doing excellent with a steady decrease in the number of new HIV infections and significant improvement in AIDS-related death again since 2003. When we look at the Middle East and Northern Africa, we're seeing rising rates of infection. But one of the areas of most significant concern is Eastern Europe and Central Europe. And when we look at the amount of resources that are available in those areas for HIV prevention, US dollars, $889 million is the current amount of financing for the overall HIV response in those areas. And so we're starting to see rises in new HIV infections, but unfortunately, rises in HIV-related death rates. And this is, when you look at the treatment cascade, this is reflected in people not on antiretroviral therapy. Untreated AIDS is a fatal illness. And if you have only 45% of your population with HIV actually able to access treatment, no comment on if it's effective or not, but able to access treatment, you're going to be seeing rates rise like this. When you've got 93% of your overall population, this is the Eastern and Southern Africa, knowing their HIV status, and 80% with an undetectable viral load, you'll start to see declines in the death rate. And this basically, in a nutshell, the regional treatment coverage for 2024 kind of says it all. The percentage of adults living with HIV who are on antiretroviral therapy, the better your rates of prescribed antiretroviral therapy, the better your survival, the better rates you see with decreased HIV transmission. And in a couple of areas of the world, Eastern Europe, Central Asia, and the Middle East and North Africa, we are seeing rates of treatment at less than 50%. And this is not how we're going to stop the HIV epidemic. This is actually concerning for seeing reverses in some of the advancements that have been made. Okay. And for the people most affected by HIV, when you look into those numbers, it's even worse for people who have marginalization, discrimination, or in some cases, criminalization. HIV prevalence rises in those populations. Viral load, successful treatment with a decreased viral load falls, resulting directly in more transmission in those populations and an overall death rate in those populations, especially men who have sex with men, commercial sex workers, people who inject drugs, transgender people, and people who are incarcerated. Those are some of the most marginalized groups that without significant attention to them, we are concerned we'll see even higher rates of transmission of HIV and worse outcomes overall, which is not how we're going to end the HIV epidemic. Now, this drug is known in the US as Sunlenco when we use it for treatment, but when it's used as a standalone drug for HIV prevention, lenacapavir, Yeztugo, an injectable, it's been making lenacapavir as a capsid inhibitor has been making waves as the game changer, the potential to change the HIV epidemic, just like the introduction of protease inhibitors in 1996 changed the death rates for HIV. So the UNAIDS director, in her forward to the UNAIDS World Report, said we started 2025 excited about a transformative opportunity to tackle HIV with lenacapavir, a new long-acting medicine that can prevent HIV infection with just twice-a-year injections. And again, we're looking forward to having, within the next few years, annual injections, monthly tablets, vaginal rings, all things that can really make a headway in HIV prevention as tools to end the HIV epidemic. So what's lenacapavir? All right, this was from an International AIDS Society talk by Joseph Aaron in 2023. And lenacapavir is a first-in-class capsid inhibitor. An oral loading dose is given, so pill on day 1, a pill on day 8. That's actually one of the options for lenacapavir. Followed by a subcutaneous injection every 6 months. And the way lenacapavir works is it stops capsid assembly. That's its mechanism of action. It's approved in patients in the US who are heavily treatment experienced. So we sometimes add this on to other medications for people who have a tremendous amount of resistance and are failing other more conventional antiretroviral therapies. But where lenacapavir has really made an impact is as a prevention, as a PrEP, an HIV preventative medication. And in the PURPOSE trials, prevention with purpose, lenacapavir was studied as an investigational twice-yearly injectable medication for PrEP, pre-exposure prophylaxis. There were originally 4, now 5 PURPOSE trials: PURPOSE 1, PURPOSE 2, PURPOSE 3, and PURPOSE 4. And PURPOSE 5 was recently started again. This was looking at PrEP with lenacapavir compared to conventional PrEP in France and the United Kingdom. So lenacapavir for PrEP, with the prevention for purpose overview, coming out of some of the HPTN studies. The goal was to see how this preventative medicine worked compared to traditional preventative medicines for PrEP, which is basically Truvada. So these arms had no placebo drugs. And the results for PURPOSE 1 and PURPOSE 2 have been released. PURPOSE 3 is still in phase 3 studies, and this is looking at lenacapavir in US women, and PURPOSE 4 is looking in the US as people who inject drugs. The big study, PURPOSE 1, was published in the New England Journal of Medicine in July of 2024. And this was a game changer. When this study was presented in the summer of 2024 at the IAS convention, the presenter got a standing ovation. This is a game changer. 5,000 women, cisgender adolescent girls and young women in South Africa and Uganda were studied with lenacapavir, an every 6-month subcutaneous injection. There were 0 infections in the lenacapavir arm. 0. Over 90% adherence rate less than 1% rate of discontinuation, and 193 pregnancies with no mother-to-child transmission and no adverse outcomes. Absolutely phenomenal as a game changer in HIV prevention. Purpose 2 looked primarily at men who have sex with men in the US, South Africa, Peru, Brazil, Mexico, Argentina, and Thailand. And there were 3,265 participants. In the Len arm, there were 2 infections, and there were 9 infections in the Truvada arm, the tenofovir emtricitabine arm, with a 1.2% discontinuation rate for lenacapivir, which was still pretty low. Interestingly, the 2 infections that were diagnosed occurred after the first injection of lenacapivir before the second injection. No resistance was seen, so these were thought to potentially be early infections before lenacapivir levels had perhaps reached therapeutic levels. So this is the editorial about PrEP using lenacapivir from July 24th, 2024 in the New England Journal of Medicine. And the results of the PURPOSE trial have now raised a whole bunch of scientific questions. For example, the Levi syndrome, which we see with injectable cabotegravir, is kind of a smoldering presentation for HIV infection. How is Len going to actually change diagnostic challenges we may see with rare acute HIV infection in patients on lenacapivir injections? How are we going to, if people have protection against HIV infection from lenacapivir, what happens to other STIs like syphilis, chlamydia, gonorrhea in terms of prevention strategies? What about emergent viral resistance? These are all major questions that these lenacapivir studies have raised. Now, the US FDA did accept Gilead's new proposal, and on June 18th, 2025, lenacapivir was approved in the US for PrEP. And this is a recent article from Lancet Infectious Diseases. It was the opinion article about lenacapivir from Gilead Sciences. It's really time to change the game for everybody. This is a quote from the editorial. A cost analysis presented by Andrew Hill from the University of Liverpool at ID Week 2025 showed that lenacapivir could be sold at a cost of $25 per person per year in LMICs, which would still allow Gilead Sciences to make a considerable profit while massively expanding the number of people with access to this drug. So we actually right now have all the tools that we need to end the HIV epidemic. We also have all the tools that we need to end polio, measles, and other things along, with smallpox. We have the tools to do this. Treatment as prevention, U equals U, and PrEP and PEP. But the reality is that it's going to be interesting to see how we get there, okay? So briefly, lenacapivir pricing and availability in October 2024, before it was approved in the US, Gilead did grant 6 generic licenses. So hopefully manufacturing will be rolled out no later than 2027 through companies that access these 6 licenses. Unfortunately, though, 25% of new HIV infections are occurring in regions excluded from the generic license, including the US. And in South Africa, it's priced probably higher than we would want it to be priced at $60 per person per year. According to the director of UN AIDS, at the current price, lenacapivir will remain an unreachable preventative tool for many individuals at risk of HIV. And therefore, if this game-changing medicine remains unaffordable, then it will change nothing. So we've moved away from, in 2014, we announced the World Health Organization, US was a major part of this, EHE goals, and the HIV epidemic goals were 90-90-90 by 2020, 95-95-95 by 2025 in order to end the HIV epidemic. And we're changing that up a little bit. We now have the 40+20 goals, which is 40 million people on HIV treatment with viral suppression. So we got about, 40.8 million people estimated currently to have HIV infection. So you're pretty much talking, this is the goal of everybody with HIV on treatment with an undetectable viral load. It's a very ambitious, excellent goal. And 20 million people at risk for HIV infection on effective preventatives like lenacapivir. This is the new global AIDS strategy to end the HIV epidemic by 2030. And so just the last few slides to close, as the director said, the AIDS EHE goals and the HIV epidemic goals are in flux right now. We still have the power with some of these new tools for transformation. International assistance has been accounting for about 80% of the preventative programs in low and middle income countries. And some of the modeling that's coming out has shown that if funding is permanently removed, we are looking at 6 million additional HIV infections, additional 4 million AIDS-related deaths by 2029. However, there's some hope because Global Fund's recent 8th replenishment conference generated pledges of $11.34 billion. And it's hoped that this will overflow into some regions like Eastern Europe and Central Asia, where less than $1 billion a year is spent in overall preventative efforts. And there is hope that there's going to be bilateral agreements to continue funding over the next 2 to 5 years so that antiretroviral therapy can be delivered to people who need it so they get an undetectable viral load, and effective preventative medicines can also be delivered. So overcoming disruption, transforming the AIDS response was an appropriate World AIDS Day theme, I think. And a key thing is going to be investments. And the HIV financing architecture is undergoing current unprecedented changes. And the future of PEPFAR is going to be huge. If it doesn't return to 2024 funding levels and stay there, not just return there, but stay there, funding gaps could widen and things could worsen. So remembering, we have the tools we need, and we've had them since 2014. We have the tools we need to end the HIV epidemic by diagnosing all people with HIV as early as possible so people know their status. Everybody needs to get tested. Everybody needs to get tested without discrimination, without risk assessment, just tested. People that are infected need to be treated as rapidly as possible, and they have to achieve an undetectable viral load and maintain it. That will restore a normal CD4 count. That will give morbidity and mortality rates and levels similar to people without HIV. That will stop partner transmission, mother-to-child transmission, and probably will decrease also with injection drug use, person-to-person transmission. Preventative strategies need to be aggressively employed, whether it's male circumcision, pre-exposure prophylaxis with lenacapivir, syringe services programs, and then again, remembering that U equals U is probably the best preventative program we've got out there. Know your HIV status and get an undetectable viral load. And then we still need to keep monitoring this so we can quickly prevent outbreaks, especially in communities at risk, such as people who inject drugs, so we can try to stop outbreaks as they occur. Put that the old principle from the smallpox days of the ring vaccinations, the ring interventions. So that was just a brief tour through the UN AIDS World AIDS Day report for 2025. And thank you so much for letting me share that if you have, and happy to entertain any questions if you have them.
Thank you very much, Dr. Joan. That was a great presentation. Any questions, or I can just add something? HIV, it's a a real threat to global health, and that's why the CDC, WHO, and other organizations came up with strategies to eliminate HIV by 2030. And I had the privilege, like a couple of years ago, to work on, like some strategies, because the goal is there, is very big and bold, but there are some strategies, to really get there. I had the privilege to work on a strategy called status neutral care approach. So the approach is like, when a patient comes to the clinic, they have to get tested, regardless of the HIV status. When they test positive, they get into treatment. And when they test negative and they're at high risk, we start, like PrEP and all preventive measures, just to make sure that we capture, HIV positive and HIV negative and prevent, the spread of. But now with all the funding cuts, like especially like last week and a couple of weeks ago, I've been reading a lot of news on HIV outbreaks, in many states here in the US, and it's really unfortunate, but the goal is there. We have all the tools, but it really requires a lot of collaboration and especially like in Africa, for instance, there's been a pause on fundings, and that's really affected so many people. And this morning I just read, a news from WHO that the US just released, I don't know, the sun, a contract with the government from Uganda, for the next 5 years, if they can, work together to eliminate HIV. And basically the world wants, more fundings and to work, toward eliminating HIV by 2030. It's a bold goal, but everything's doable. Thank you, Dr. Duggan, for this great presentation.
Ma'am, before getting into the questions, I just wanted to brief that we have a varied audience with us today. So we have clinicians with us, microbiologists, public health professionals, and even hospital administrators. So I request everyone, if you have any question, be it regarding AIDS, public health, or in larger the healthcare domain, you are all welcome to ask. And we can please get started with the questions.
Hello. Dr. Babu, can I ask a question from
Yeah,
ma'am?
sure. Yes, go ahead.
Hello, ma'am. I'm Dr. Disha Dhariwal, and I have done my MBBS, and currently I'm pursuing my post graduation, my MD in microbiology. So, ma'am, because we are usually into infective diseases and we read a lot about them. So, ma'am, about HIV, I always used to wonder that we are having such good medicines. We have NRTIs, NNRTIs, protease inhibitors. Despite the fact we have such availability of drugs, we still the mortality rate of HIV is very high, ma'am. What is the reason that why we are not able to contain the mortality rate? Why it is so high?
Yeah. So it's multifactorial, but probably the main reason is that people don't get diagnosed early. So by the time they're diagnosed, many people actually are diagnosed when they have AIDS. And so they have low CD4 counts and they may not completely immune reconstitute, or death occurs while they are immune reconstituting. So it's kind of like pick any, I'm trying to pick a disease, infective endocarditis, right?
Yes, ma'am.
By the time you've got significant damage to the valves, we can sterilize the blood. But after that, you're going to have other things that are going to support you, valvular surgeries, treatment of congestive heart failure, and you'll never do as well as if we had treated you the first hour you had Staph aureus bacteremia, right? So sometimes the damage is a little bit done, And that's one of the things that we do look at for this reason is people's CD4 count when they're diagnosed, because that gives us an idea of the kind of impact we're going to make in the system. And if we're diagnosing everybody at a CD4 count greater than 500 cells per ml, so when they have a normal immune system, and get them on antiretroviral therapy, we're going to do much better than if people are coming in with CD4 counts less than 50. So one of the big things we think is just delay in diagnosis, because most people don't come in to get tested until they're sick. We don't do as much routine screening as we should, just of everybody, to try to preserve health. We try to find people when they're sick and restore their health. And we won't move the needle as much as we should on morbidity and mortality till we shift the mindset.
Yes, ma'am. Yes, ma'am. That's really true, ma'am. Thank you so much, ma'am.
Thank you.
Anyone else?
Good evening, doctor. That was a great presentation given by you. I just had a question regarding the cost that we discussed. Like we were discussing, it's around $60 in Africa. So how are
South
we,
Africa.
how are we planning to, if we plan to, how are we planning to cut down the cost? Because quality is something that won't at all be hampered. So yeah, that is my question.
That's a great question. So Gilead is working aggressively on trying to keep the cost affordable for many areas of the country, but not for others. So in the US, the price of lenacapivir is $28,000 per year, which makes it unaffordable for the vast majority of people. And insurance companies often don't cover it. And so and then in other areas, even areas where like the Gates Foundation is trying to step in to pull up get some pricing equality. Some of the modeling data has shown that unless we can get it under $20 per year, we're not going to be able to have widespread implementation of this as a preventative in most countries. And yet we can do that and still, still be a profitable drug. So I don't know how this is going to happen. This was actually a big focus of the UN AIDS report, how we're going to implement these things, because countries have other crises. They have malaria, they've got TB, there's HIV. It's, sometimes the microbes seem to be winning every time we turn around. So I don't know how this is all going to work out. More will be revealed. I do know many people think that we'd like to see PEPFAR funding restored back to 2024 levels, because with this new game-changing medication that Gilead has released at a low price, this makes it, if we can just get back there, really, really potentially a goal we can hit for prevention.
Thank you, ma'am.
Anyone else? I think there's no more question coming in, ma'am. So I just wanted to mention that honestly, this webinar, after hearing it, it felt really optimistic, and you could see a light at the end of the tunnel when it comes to HIV, I mean. So truly inspiring. And it was really optimistic to hear those words that yes, there is a end that we can see to this epidemic. Thank you, ma'am, for sharing such valuable insights for us today. Your expertise has greatly enriched our understanding of the current HIV landscape. Thank you everyone for joining the session. We appreciate your time, engagement, and commitment to global health. We hope to see you again in an upcoming GHQA Wednesday webinar. And have a great day, great evening, great afternoon. Thank you, everyone.
Thank you. Thank you very much. Thank you. Bye-bye.
Bye, ma'am. Thank you. Thank you, everyone.
Bye-bye.